Welcome to PT Microlessons, fast lessons with big impact. In this lesson, we're going to look at pulmonary disease from a broad perspective. We'll learn how pulmonary diseases are classified as obstructive or restrictive. This overview will provide the framework we'll use to understand the major pulmonary diseases and their implications for physical therapy throughout the rest of this series. Let's start with the two common ways pulmonary disease is classified. The first is by time course. Acute diseases develop suddenly and are typically short in duration, whereas chronic diseases persist over months or years and often require long-term management. The second method is by ventilatory pattern, which describes how a disease affects breathing. Obstructive diseases make it difficult to move air out of the lungs because the airways are narrowed or blocked. Restrictive diseases make it difficult to fully expand the lungs because the lungs, chest wall, or both cannot expand normally. Both classification systems are important, and many pulmonary diseases fit into both. For example, pneumonia is generally an acute restrictive disease, while COPD is a chronic obstructive disease. However, throughout this series, we will primarily organize pulmonary diseases as obstructive or restrictive because understanding the underlying ventilatory pattern provides the best framework for explaining the pathophysiology, recognizing clinical signs and symptoms, and guiding physical therapy management. First, let's look at obstructive lung disease. The 5 major obstructive diseases are emphysema, chronic bronchitis, Bronchiectasis, asthma, and cystic fibrosis. As shown in the illustration, emphysema damages the alveoli, causing a loss of elastic recoil and air trapping. Chronic bronchitis is characterized by inflammation and excessive mucus production that narrows the airways. Bronchiectasis causes permanent dilation and damage to the bronchi, leading to mucus retention and recurrent infections. Asthma produces reversible airway narrowing due to inflammation and bronchial hyperreactivity. Finally, cystic fibrosis is a genetic disorder that produces thick, sticky mucus, resulting in airway obstruction and chronic respiratory infections. Although each of these diseases has a unique underlying cause and clinical presentation, they all share one common feature: airflow limitation, making it difficult to move air out of the lungs during exhalation. Notice the comparison in the lower right corner of the slide. A normal airway has a wide, open lumen, whereas the obstructed airway is narrowed by inflammation, mucus, airway remodeling, or loss of structural support. This narrowing increases resistance to airflow, particularly during exhalation, making expiration the hallmark problem in obstructive lung disease. Although the underlying causes differ, the mechanism of airflow limitation is similar across obstructive lung diseases. The airways become narrowed, blocked, or collapse prematurely during exhalation. As a result, air can enter the lungs more easily than it can leave, causing air trapping. Over time, this trapped air increases the amount of air remaining in the lungs after exhalation, leading to hyperinflation. The key concept to remember is that the primary problem in obstructive lung disease is reduced airflow, not reduced lung volume. In fact, lung volumes are often normal, or even increased, because air becomes trapped within the lungs. This is why patients with obstructive disease often have prolonged expiration, difficulty fully emptying their lungs, and increased work of breathing. Now let's look at the common clinical signs and symptoms of obstructive lung disease. Because patients have difficulty moving air out of their lungs, they often experience dyspnea or shortness of breath, along with a chronic cough and reduced activity tolerance. As the disease progresses, some patients develop digital or nail clubbing, which is associated with chronic hypoxemia and is more commonly seen in bronchiectasis and cystic fibrosis. Chronic air trapping can also lead to a barrel chest, where the chest remains expanded because the lungs are chronically hyperinflated. To help overcome airflow limitation, patients often recruit the accessory muscles of respiration, adopt a tripod position, and use pursed lip breathing. These strategies help reduce airway collapse during exhalation, improve expiratory airflow, and decrease the work of breathing. As you progress through this series, you'll see that while each obstructive disease has its own unique features, these are many of the common signs and symptoms you'll encounter across the obstructive lung diseases. Okay, let's turn our attention to restrictive lung disease. Restrictive lung diseases are characterized by normal airflow but reduced lung volumes. Unlike obstructive diseases, the primary problem is not moving air out of the lungs, but rather getting enough air in. This occurs because the lungs, chest wall, or both have reduced compliance, making them stiff and more difficult to expand during inspiration. Restrictive lung diseases are further classified as either intrinsic or extrinsic. Intrinsic, also called parenchymal, directly affect the lung tissue itself. Examples include pulmonary fibrosis and other interstitial lung diseases, where inflammation and scarring reduce lung compliance and limit expansion. Extrinsic, also called extrapulmonary or non-parenchymal, occur outside the lung tissue. These include disorders of the chest wall, pleura, neuromuscular system, and obesity, all of which restrict lung expansion despite relatively normal lung tissue. In other microlessons, we'll explore both intrinsic and extrinsic restrictive diseases and discuss how they affect breathing, exercise tolerance, and physical therapy management. Building on that, we can now look at the common examination findings associated with restrictive lung disease. Although both intrinsic and extrinsic restrictive diseases reduce lung expansion, their physical examination findings can differ because the underlying problem is different. Intrinsic or parenchymal restrictive diseases affect the lung tissue itself. Patients commonly present with dyspnea, rapid, shallow breathing, and reduced activity tolerance. On auscultation, they often have fine inspiratory crackles, sometimes called dry or Velcro crackles, which occur as stiff fibrotic alveoli reopen during inspiration. In advanced disease, cyanosis may also be present. Extrinsic or non-parenchymal restrictive diseases involve structures outside the lung, such as the chest wall, pleura, neuromuscular system, or obesity. Because the lungs cannot fully expand, you'll often observe reduced chest wall excursion, increased accessory muscle use, and sometimes a forward flex posture as patients attempt to reduce the work of breathing. Like intrinsic disease, these patients frequently experience dyspnea and reduced activity tolerance. Although the examination findings vary somewhat, both intrinsic and extrinsic restrictive diseases share the same hallmark feature: difficulty getting air into the lungs because lung or chest expansion is limited. Okay, now for the key takeaways. Obstructive lung disease is characterized by difficulty getting air out of the lungs due to reduced airflow, leading to air trapping. Restrictive lung disease is characterized by difficulty getting air in because the lungs or chest wall cannot fully expand, resulting in reduced lung volumes. If you remember one concept from this lesson, remember this: obstructive diseases affect airflow, while restrictive diseases affect lung expansion.
That's it for this PT Microlesson. Like and follow @PT Microlessons for more fast lessons with big impact on physical therapy topics.